I'm a pediatrician and a neonatologist from the Dartmouth Institute in New Hampshire, USA. And it's my pleasure today to be facilitating and coordinating this session on international health. The first presentation today will be by Kathleen Hill and Tamar Chitasvili. And they will go for a total of 45 minutes. And after that, we have Pierre Barker and his team, who will go for another 45 minutes, for a total length of 90 minutes. And both speakers have ensured that we have a lot of time for questions and answers. So as they're doing their presentations, please make little notes to yourself and then engage in an active discussion and question and answer sessions. There are 2 mics on either side of the hall. And we also have a handheld mic that I can bring around when you have questions or comments. So the first presentation will be by Kathleen Hill and Tamar Chitasvili. They will do a little introduction of themselves and then launch into the presentation. Welcome again.
Thank you very much. Welcome, everyone. We're delighted to be here. And I just thought I would introduce us, and then we'll begin the presentation. So I'm Kathleen Hill, and this is my colleague, Tamar Chitasvili. And we are both based with the University Research Company, which is a US-based organization that does improvement work worldwide. And we're going to be presenting results of improvement work that we are currently undertaking in the Europe and Eurasia region. I just wanted to ask before I begin, because it's always helpful to know a little bit about the audience, how many of you are currently working on non-communicable diseases? Is there anyone in the room? Okay, a few. And how many of you are not working on non-communicable diseases but are interested and would like to be working in this area? Okay, thank you. So, to give you a little, just to quickly review the presentation outline, we'll be talking for a few minutes about the burden of NCDs globally, and then describing some selected results of a 4-country assessment of ambulatory NCD services that Tamar Chitasvili and I conducted in Albania, Armenia, Georgia, and Russia. And then we'll share with you some initial stages of follow-on improvement work, implementation work that's beginning in Georgia. And Dr. Chitasvili is our chief of party in Georgia, so she'll be sharing more specifically how we've begun this work. And then we're really looking forward to having an open discussion with all of you. Many of you, I imagine most of us here, are deeply interested in improvement, and we would love to have your thoughts after hearing what we're going to present. I'd like to just say a few words about NCDs. I think I always find it a little bit ironic because I work in global health in many regions of the world, and I also practice part-time as a physician in the US. I take care of NCDs every day, except I wouldn't think of what I do as non-communicable diseases. It's just good primary care. In the global arena, all of a sudden, everyone is talking about what I think many of us who are working in high-resource settings have been doing for years, and everyone's talking about it as non-communicable diseases, chronic care, because I think historically we've invested so many resources and so much effort, understandably and justifiably, into acute care, infectious disease, maternal newborn nutrition, but I would like to also argue that we have really neglected, particularly in low and middle income settings, the problem of non-communicable diseases, chronic disease, which imposes a tremendous burden. So I'm quite passionate about this topic, and we're really glad to share with you what we're finding. So when we're talking about the global burden of NCDs, what are we talking about? Well, we're talking about 63% of mortality worldwide, projected by WHO to represent 75% of mortality by 2020. 36 million deaths in 2008, and 80% of this mortality burden occurs in low and middle income countries, where the capacity for prevention care is severely constrained due to some of the historical patterns around funding and investments in these regions. There's huge economic and human impact for these diseases. 30% of NCD deaths in low-resource countries occur under the age of 60. So many of us in this room would be approaching, our life expectancy at this point if we were living in a low and middle-income region. And I think any of us who in this room who live with an NCD or love someone who lives with an NCD, we know very much what the human costs are. They're huge, the suffering. And then there's huge economic impact. And I think there's huge impact in terms of costs of providing care for NCDs, as well as economic impact due to lost productivity. And when we look, not surprisingly, at the comparative age-adjusted death rate for NCDs, we see that it's 65% higher for women and 85% higher for men in low and middle-income countries, with the highest burden by age-adjusted in the Africa region. So fortunately, there's really, I would say, in the last decade, a real global momentum that's now building. In 2001, the World Health Assembly endorsed a global strategy for prevention and control of NCDs. Last September, the UN held a high-level NCD meeting in New York, which convened governments from all over the world, and it was the second ever UN high-level meeting for health, the first being for HIV. So I think that this UN-level meeting really gives you an indication of how important, not only those of us working in the healthcare sector, but also how important governments, politicians, financial ministers see this issue. It has huge economic impact. And just 2 weeks ago, WHO issued a proposed voluntary global NCD monitoring framework that includes 5 global NCD targets. We'll be seeing, the World Health Assembly will be looking at this monitoring framework in May and potentially adopting it. So those of you who may be working on NCDs might be interested to go to the WHO website and look at that framework. So which NCDs are we talking about in terms of burden? So cardiovascular disease, I've highlighted it in red. It's also, I think, of blood. It's by far the elephant in the room. It's 48% of all non-communicable disease mortality is due to primarily heart attack and stroke. This represents 17 million annual deaths. Cancer is second after cardiovascular mortality, and these are global figures now. There is some variation by country, but in general, countries follow this same pattern. And then chronic respiratory disease, diabetes, mental health. These are the highest burden NCDs, speaking by numbers, but I think it's important to point out that, and many of us in higher resource settings are working on these different diseases, that NCDs also include, of course, neurological diseases, seizure disorders, Parkinson's disease, and we don't in any way mean to ignore those, but I think that around the UN high-level meeting and the WHO advocacy, there's been an emerging consensus that in the resource-constrained world in which we live, we really need to rally our resources and investment around the highest burden diseases. So these 4 NCDs that I just showed, cardiovascular disease, some cancers, diabetes, and chronic respiratory diseases, share common behavioral and physiological risk factors for the most part. And this provides a very important opportunity to focus our healthcare improvement work on these shared modifiable risk factors, particularly when we're talking about primary prevention and prevention of progression to disease in the first place. And you can see here the behavioral risk factors are tobacco use, physical inactivity, unhealthy diet, alcohol abuse. And these behavioral risk factors lead to the physiological risk factors: high blood pressure, elevated cholesterol, obesity, some of the cancer-associated infections connected with cervical cancer, like human papillomavirus. And increasingly in high-resource settings, these are not just diseases of adults, these are diseases of children as well. And of course, these risk factors, these common shared risk factors, are very much connected to very rapidly increasing rates of urbanization and globalization and change in lifestyles. So WHO, in its report that it issued on the global status of NCDs just prior to the UN high-level meeting, just within the last few months, I think did quite a nice job of summarizing what the current evidence tells us in terms of what the best buy interventions are for prevention and control of NCDs. And by best buy, high value, cost effective, clinically effective, and in general, we can categorize best buy interventions for prevention of control NCDs into population level interventions and individual level interventions. So the population level are, smoking bans, processed food regulation, tobacco, alcohol taxation. Individual interventions are directed to individuals in terms of primary prevention, secondary prevention, and treatment. And in general, most experts agree that it's really a combination of these two kinds of interventions that have the greatest impact. So for example, in the UK and in the US, there's been close to 35 to 40% reduction in cardiovascular mortality over the last 20 years. This is in spite of, all kinds of terrible lifestyles. And most people, most experts agree that this reduction in these two settings has been due to about 50-50 contribution of population level and individual interventions. We're going to be focusing in our talk on the individual interventions, but I do want to mention the population because they're extremely important, and hopefully we'll all find ways to work in more multi-sectorial ways going forward. We're now going to talk for a few minutes about our assessment, and the objectives Tamar and I conducted. So this is sort of the global setting that I've just shared, and now we're moving to a 4-country assessment that we conducted in Georgia, Albania, Armenia, Russia, to look at the quality of NCD care for women of reproductive age. This was funded by the USAID Bureau out of Maternal child health funding, which is why the women of reproductive age, and also to look at the health system functions that are essential for supporting these best practices. And we also looked at provider and client knowledge, attitudes, self-reported practices, behaviors that influence NCDs. I'm not going to spend a lot of time on this table except to say that we looked at each of the disease categories in the left column, cardiovascular disease, cancer, diabetes, chronic respiratory, and mental health, and we looked at primary prevention, modification of risk factors, as well as quality of case management for established disease. Today, we're going to be focusing on just a few selected results for cardiovascular disease and chronic respiratory disease because of our time constraints and because this is what we're focusing on in Georgia, as you'll hear. But I would like to say that the results related to cancer screening and mental health are actually probably the very weakest in the survey. And so I wouldn't want you to leave thinking that those areas don't matter. They matter a lot and have tremendous quality gaps. So we conducted the assessment in an average of 10 to 12 facilities per country, and here you can see the characteristics of the facilities. And we chose facilities with a deliberate sampling methodology that included a higher proportion of urban ambulatory care settings because we knew that that's where the highest density of population resides, and a higher mix of public because these are post-Soviet countries for the most part, that for the most part of public health systems, although you'll be hearing from Tamar about some huge transitions that are occurring in Georgia. We included a combination of primary health center, polyclinic, which are mixed primary specialty care centers that are very common in post-Soviet countries as a legacy of the Soviet era, and hospital-based ambulatory centers. And we looked at 5 different kinds of data to try to be able to put together as comprehensive a picture as possible without the gold standard, which would have been direct observation over a period of time. We looked at facility inputs and general organization of service delivery, chart review, manager interviews, provider interviews, and client interviews. And you can see the numbers there. We reviewed about 650 charts, close to 400 clients, and about 270 providers. And to share a couple of the results with you, this is the results of the chart review. And among 658 charts in the 4 countries, we actually found quite good results for screening and documentation of blood pressure. 83% of charts included a blood pressure within the last 12 months, which actually I was very pleasantly surprised by. We would probably find much lower levels in some settings. And we found that an evidence-based antihypertensive was prescribed if recorded blood pressure met criteria for hypertension in 89% of cases. Still some missed opportunities, but quite strong. When it came to whether cholesterol had ever been recorded, only 30% of charts recorded a cholesterol, and in the presence of high lipids, high cholesterol, only 22% of charts had a statin or dietary counseling. And we know that primary prevention targeting high-risk individuals who have an over 15 to 20% risk of a cardiovascular event in 10 years, targeted primary prevention using multi-drug therapy, aspirin, as well as statin, as well as blood pressure management, can significantly reduce progression to cardiovascular disease. So the cholesterol finding is a definite missed opportunity. And we found that weight was classified, even recorded at all, in 12% of charts, and almost never classified in terms of obesity or overweight, and very low rates of exercise and dietary counseling. So once again, here are the behavioral and physiological risk factors that we would ideally like to see at the primary care level. When we examine charts in terms of tobacco, in the bottom here, 25% of charts documented ever at any time whether or not a patient was a smoker, so clearly a missed opportunity for interventions, especially given high prevalence of tobacco use. And even among patients who were smokers, with the cholesterol results, only a third of those patients across the 4 countries on average in the charts benefited from a tobacco cessation intervention. And clearly the charts may underrepresent what's happening in clinical encounters, but they give us some idea, and we do also have provider and client data that for the most part correlates with the chart review findings. We found that for asthma and COPD, chronic obstructive pulmonary disease, that practices were actually better, but if you look at percent ever hospitalized, 46%, that's an extremely high percent that probably indicates a combination of poor patient adherence with recommended treatment, poor quality of care, and probably financial incentives for hospitalization. And it's hard for us to sort that out, but it certainly is a flag. This is an example of a medical chart from one of the Georgia polyclinics that we visited, and this is in Georgian, which Tamar could interpret for us. And really the purpose of this picture is just to show you our findings. A big part of our assessment of charts was not only to look at adherence with best practices, but also to look at the extent to which charts were organized to support the best practices. Was there a clear section for, list of medical problems, for list of medications, for tracking things like blood pressure over time? And we found that in general, across the 4 countries, there was very, very poor standardization and organization of charts to support best practices by providers. It was a little bit stronger in Georgia than in the other countries, but even in Georgia, when there were the charts, there was, some irregularity in terms of documentation of values within the chart sections. This is a bar graph that shows you results across the 4 countries for how providers rated themselves in terms of their level of confidence for screening and treating specific NCDs. And I think one thing that's quite striking here is the degree of agreement among the 4 countries, which tells us something about the regional needs. And you can see that for hypertension and cholesterol, we have somewhat stronger results, but very quickly as we get into diabetes, cervical cancer treating, depression, alcohol, very low levels of provider self-reported confidence. And these are medical doctors who've been through medical training. And when we look at some select examples of knowledge questions, we see that there are also important gaps that I think are not surprising in light of how providers rated themselves in terms of self-confidence. So we see that, for example, less than 50% of physicians could correctly identify international diabetes diagnostic criteria using international criteria, that less than 50% of physicians could identify correctly on a multiple choice questionnaire the need for aspirin and beta blocker after a heart attack. So going forward now, in terms of physicians that reported no access to specific evidence, there was quite a quite a high number, except for in Russia, of physicians who reported that they did not have access to what we would consider, important sources of evidence like international journals, national guidelines, professional society guidelines. I'm now going to, having set the stage, now going to invite my colleague Tamar to share with you some of the follow-on work in Georgia.
Thank you, Kathleen, a lot. It was a real fortune for us that after assessment, after directly assessment, we had and granted with the opportunity to work on follow-up implementation on improving quality, consistency, and continuity of medical services in Georgia, and also address the issue of improving access and use of evidence-based medical information by Georgian physicians. As Kathleen described in the assessment, there were a lot of challenges and opportunities for us to work on specific care practices. And based on the highest disease burden and mortality in Georgia, we identified, as Kathleen mentioned, cardiovascular diseases and cross-cutting risk factors, asthma, COPD, and risk factors in adult patients, and pneumonia and asthma management in pediatric patients. It's a clinical focus area for our implementation work in Georgia. So one of the components of our project is specifically designed to work and demonstrate quality improvement practices in the region, but it is very fortunate for us that we granted the possibility to work across all levels of health service delivery system. Our four-country assessment was limited with ambulatory care settings only, but now we had the possibility to and have the possibility to work starting from the village doctors to all levels of ambulatory care, and then to hospital until to the highest level facilities as a referral facilities. And obviously many challenges and many opportunities with regard to that, especially to address the issues with regard to continuity of care and follow-up treatment for different priority clinical conditions. And obviously, our interventions are not only concentrated on one region, but we try to demonstrate best practices and to use those tools through different tools, and use and institutionalize these tools through different strategies at the national level, like incorporation of best by high impact services in publicly funded health insurance programs, health programs, and also private insurance programs, as well as define and support development of hospital accreditation and certification system in Georgia, and as well as support development of performance-based incentives for providers and facilities to use modern evidence-based practices. So as I described above, we are working across the entire level of service delivery system, at ambulatory care, hospital care. At each level of care, we aim to improve care processes, including diagnosis, regular monitoring of disease progression, choice of best treatment, and also improve patient behavior and patient self-management support. And between different levels of care, we are concentrate on improving continuity of care and coordination between different levels of health service delivery system. And as mentioned above, we are concentrating on high burden diseases both in pediatric and adult patients, and those are mostly pulmonary and cardiovascular diseases, including their risk factors and including prevention and obviously management of those diseases. Obviously, you might see that this is very ambitious project that could be implemented and will be implemented in 1 year. 1.5 year, it's almost 6 months already went at that time, but it is very important to see that we are concentrating only very high impact and selected practices that are based on demonstrated poor quality of care from one hand, and from another, potential to dramatic improvement in a very small period of time. And obviously, these interventions are very cost-effective and high-impact interventions. This is the slice of the system on which we work. Those are collaborative sites, family physicians and village doctors in the bottom, and some hospital facilities, general hospital, regional hospital and referral hospital. Up to now, we conducted situational analysis in terms of quality gaps. We knew quite substantially what was happening in ambulatory facilities, and we, after the project was started, we conducted a snapshot assessment of hospital quality of care with regard to priority clinical areas, and based on this, we defined very focused clinical intervention practices. Currently, we are in the process of formation of quality improvement teams in each facility, and very actively involved in developing intervention and control baseline assessment to guide implementation, design, and of course permit impact evaluation of our project. We specifically focus our analysis on quality improvement and process related to care, as well as to demonstrate cost effectiveness and efficiency of quality improvement interventions in collaborative improvement facilities. Just to give you some clear picture from where we start the project, we practically present some results, selective results at the ambulatory level, and then some selected results at the hospital level. This 4-country assessment showed us that Georgia was quite strong in terms of patient and provider reported single primary care provider for the patients, but generally it was data that was generated under the system was not used as an evidence for making any decisions with regard to quality of care services. Patient self-management support was also weak and was practically no NCD counseling and teaching services available in the facilities, and there was non-designated staff in Georgian facilities, Georgian ambulatories for patient self-management support. In terms of continuity of care, follow-up was also very weak, especially from client-reported practices. And you can see that we try to triangulate our results from different sources so that we have more or less reliable data and results. And it is very important also to mention that this is happening in facilities. This is a problem in facilities, but the significant problem also is that most of people don't utilize services at all. Ambulatory service utilization in Georgia is one of the most weakest one, and contributes 2 patient visits per year. That is the lowest among even post-Soviet countries. And this is very important because here is huge unmet need in terms of population level, prevalence, and facility-based treatment of those services. For example, from this slide, you can see that despite the fact that blood pressure is quite well managed at ambulatory care settings, as Kathleen mentioned, blood pressure is documented in 81% of charts. There is huge untreated hypertension among the population that contributes about 73% in male population. Similarly, high cholesterol is quite high in at the population level, but unlike with the previous case, even the proper management and screening is also very low in facilities. And you can see that cholesterol was recorded ever only on 9% of medical charts, and statin or counseling in case of high lipids was only recorded in 8% of charts, and a patient ever reported cholesterol tests conduction in 5%. The same are results in terms of overweight and obesity. About 75% of population are either overweight or obese, and despite the fact weight classification is not recorded in charts, and was recorded only in 9% of cases. Similar are results and huge unmet needs at the population and facility levels in terms of dietary counseling, physical activity counseling, and smoking cessation and counseling as well. So you can see I will not concentrate specifically on those results. And as Kathleen mentioned, the management of asthma was quite impressive at the ambulatory level in Georgia, but here is huge percent of hospitalization cases in case of asthma patients at the ambulatory level. And when we had the possibility to analyze these results in light with the hospital results, we have seen that at the hospital level itself, asthma is very poorly managed. No nebulizer treatments at all in any facilities. Non-evidence-based medications administered to most of the patients, practically with intravenous eophylline and natrichlorid fluids. No severity classification was conducted in any charts to guide the treatment, and spirometry was not available in most hospitals. Very striking are results in terms of hospital management of pediatric pneumonia. On average, 10 medications were prescribed per patient, and most of them were non-evidence-based, and you may all agree that there is only one antibiotic needed and maybe also antipyretic if the high temperature. So huge possibility and huge opportunity to improve rational use of medication in this regard. And it is also important that for pediatric patients, 3-4 broad-spectrum antibiotics were prescribed at the same time. And in terms of service delivery and organization at the hospital level, it was very striking to see that vital signs, the bundle of vital signs, was recorded in charts only in 11% cases. And there was very weak discharge planning and practically no communication between higher level and lower level facilities with regard to patient follow-up treatment. And in terms of acute coronary syndrome management, practically evidence-based medications were prescribed in from 22 to 33% cases, and in only 15% cases oxygen was given. And this slide also demonstrates how poor the management of acute coronary syndrome was at the hospital levels, especially in terms of risk factors, screening, and also counseling and discharge on specific risk factors, and also evidence-based bundle during the discharge and during the ongoing treatment of acute coronary syndrome. So this is the kind of where we start the project. We have significant challenges and also opportunities for improvements. Maybe Kathleen now leads discussion about what suggestions you have, what is your recommendations to how we can move forward, and then maybe I will also give a little bit context of Georgia health system so that you are more familiar what's going on there.
Thanks. Well, maybe we'll both just.
Thank you. Thank you, Kathleen and Tamar. We have about 10 minutes for discussion now, so if you have any questions, please raise your hands and I'll bring the mic over. Yes.
Hi, thanks for a really interesting presentation. My name is Dorothy Flatman. I'm from the Health Foundation in the UK. We're running a national programme on long-term conditions in 7 sites, and really interesting to hear about your work. I wondered if you could say a little bit more about the self-management support aspect, and just also just curious to know if, given what we heard about the paediatric treatment, if you are part of your change package is about setting up protocols for treatment. I may have missed that, and you may have said that in an earlier slide.
Do you want me to? Yeah. Thank you very much for those questions. So in terms of self-management, we only presented a snapshot of the results, but we asked a lot about self-management to both patients, providers, managers, because we knew that this was critically important. And in general, there's very little in Georgia. In Russia, it was a little bit stronger, but in Georgia, very little regular, formalized self-management procedures in terms of like group client visits, education, individual counseling, designated staff, tools, job aids. And so this is an area on which we'll be focusing a tremendous amount in our ongoing improvement. And there's a lot of potential because in most of these clinics, a doctor and a nurse sit together and provide the care, and the nurse basically just sort of transcribes what the doctor is doing, and the nurse could be playing such a more proactive role. So we'll also look a lot at task shifting, I think. And then in terms of pediatric pneumonia and protocols, yes, very much. The way we're really approaching the clinical content and the improvement is we're not so much thinking of it in terms of protocols as in trying to reduce to the absolute kernel, what are the absolute high-impact intervention packages that need to happen for every patient? And because our experience working with QI teams often, at least in these sorts of settings, is the more we can just distill it down to the very essentials and then have teams focus on that and how to overcome the implementation challenges, that often leads us most efficiently and most rapidly forward. But having said that, we do define the high-impact interventions by specific care phases, so I suppose you might call that a protocol. But in terms of sort of detailed guidelines, we're trying to avoid that, actually.
Thank you very much. Thank you very much. My name is Dr. Alexis. I'm from Ghana Health Service in Ghana, West Africa. Thank you for a very brilliant presentation. I saw a very striking relationship between what you just described and what happens in my country. And I was thinking if you could, I'm sure you didn't have much time, but you could probably throw light on the health system there for us to understand. Because if you are expecting, let's say, the doctor to be recording on tobacco use in a situation where the workload is too much, I think you'll be asking for too much. Because in my country, it will be difficult for a doctor who has so many patients to see at a day to do that kind of detailed clocking as you should. But then if doctors fail to record weight, I think that is inexcusable. Thank you.
Mm-hmm. Thank you very much. I will try to very briefly speak about the Georgian health care system, and I will very briefly concentrate mainly on service delivery issues, health financing very briefly, and about regulations. In terms of health service delivery system, as you all may know, Georgia is a hereditary of Soviet Mashko model system with very superfluous infrastructure, with lots of number of beds, for example, 22,000, when about 7,000 is needed, and with lots of physicians, superfluous number of physicians, but not evenly distributed, and with very limited number of nurses, and with limited competency of nurses as well. And in Georgia, for example, there is one-to-one doctor-nurse index is 1-to-1 when it is quite high in some other countries. And because of these challenges, it was very difficult to really support high-quality services when, for example, use of beds bed occupancy rate was about 20 to 25% in many hospitals. And because of this fact, government started very significant changes in health service delivery system and announced rapid privatization of almost entire health service delivery system, starting from ambulatory facilities to hospitals. Nowadays, and it happened very soon, it happened in 2 years, and now almost 90% of health service delivery system in Georgia is privatized and owned by about 5 to 6 big corporations owning both primary and hospital services together. And there are, in many places, especially in the districts, there are exclusive providers, meaning that one company, and those owners are mostly insurance companies. Insurance companies own entire service delivery in specific district or region. Obviously, given this context gives us many opportunities and also many challenges. In terms of opportunities, I think it is easier to address continuity of care issue in one region or district because it is owned by one owner and one corporate, and also there is significant possibility and opportunities that if we concentrate on one facility, and if insurance companies find it useful, our interventions, they can replicate those best practices in different facilities. But also here is huge challenges in terms of the issue that insurance companies owning these facilities, that they would definitely try to optimize utilization and lower the utilization of health services. But because of the fact that there are both ambulatory and hospital facilities are owned by these specific insurance companies, they can direct and more use ambulatory services than hospital services. In terms of health financing, it is also drastic changes in terms of financing the services in Georgia. In fact, during the Soviet system, as you all know, it was declared as universal coverage of the population, but it was only declared on the paper. In fact, government contributed about 20% in total health expenditures, and it was not possible with 20% of contribution to reach universal coverage, of course. And because of this fact, government declared targeted social assistance and targeted health service coverage for specifically those who are in most need, and those targeted population are mostly poor below the poverty line. So,
Thank you, Tamar. If you can make your comment very brief, that would be great. Yeah, we're out of time.
Be very quick. Hi, I'm Vanessa Halipi, coordinator of the APPG for Global Health, House of Lords, London, also coordinator of the Zambia UK Health Workforce Alliance. And my comment is very briefly, I was surprised by the lack of resources evidence in some of the countries in the research that you collated. And as a solution to that, I want to ask, what role can the internet play, and health forums, online health forums, and I'd like to just highlight HIFA 2015, which is Healthcare Information for All by 2015, which is spreading information, vital information. We work in collaboration with WHO, and if you're interested, please come and see me afterwards. I can give you more information. Thank you.
Thank you very much. Actually, as Tamar was saying, a very large component of the work, in addition to the improvement work at the demonstration regional level, is focused on helping physicians access evidence. One of the huge challenges in the region is that physicians, for the most part, don't speak English. And so everything has to go through a local professional society. And so this is a huge challenge, and we'll be trying to work very closely with the professional associations to create mechanisms to take, to try and distill evidence. So. Yeah, and also just for our Ghanaian colleague, because I know we need to stop, I work a lot in West Africa, and I just wanted to let you know one thing that's very different about this region that will really surprise you is that there's actually a surplus of providers. So it's very different than the workforce issues in West Africa. And so, once again, context really has so much impact on what the methods need to be. And I think for this region, it's more just, supporting physician-nurse teams to do the right thing. I think in Ghana, there needs to, or in West Africa, much more creative ways of, task shifting and community engagement and population level. I mean, they matter in Georgia too, but so different contexts.
Just to add only one note is
Actually,
that
we have time at the end for discussion in Pierre Barker's session too. Sorry to cut you guys off. The next session will be led by Pierre Barker and his team. Take it away, Pierre.
Thanks. Thank you very much. Hi, my name is Pierre Barker. I'm Senior Vice President at IHI, and I invite Martin and Carol to come and join us up here. Martin Msukwa is Executive Director of the Maikanda NGO, and he will be presenting some of the work that's been going on in Malawi. Carol Harridan is Vice President at IHI and leads our work in safety, and is an expert on perinatal collaboratives as well, which she started some years ago. So I think we're going to try to keep our comments fairly short. I hope in the next 15 minutes or so that we can provide you with a framework that we use to think about maternal and neonatal outcomes, improving maternal and neonatal outcomes. And I'm going to talk about different contexts. I'm going to talk about this incredible disparity that you can see on this map in maternal mortality. And I will, because we have such a short amount of time, I'm going to really just focus in on maternal mortality rather than maternal and neonatal, although they're obviously very closely linked. But I think this graph, this map here of the world is absolutely striking. And if you look at the histogram down below, which shows you the incidence of maternal mortality, and the legend here is maternal deaths per 100,000 births. And if you see this extraordinary difference in the countries in the world, from the left-hand side where you've got rates of less than 10, to the right-hand side of the graph, where you have rates of over 1,000, absolutely extraordinary. That's, and in countries, in some of the worst affected countries, the chances of a woman surviving childbirth is 1 in 7 over her life of multiple births. And so we're working in Malawi, and I'm going to be talking about Malawi, and Martin's going to give you the example of the Malawi intervention. But I also would draw your attention to the other data on the slide there. The second example is the United States, which has a recorded maternal mortality rate of 24, which is quite shocking, and we'll get into a little bit more detail about that in a moment. And then in Northern Europe, the Scandinavian countries, the rates are very low. The rate there that you see is for Denmark, but there's similar rates in the other surrounding countries. So the challenge that I put to you is, can we arrive at a sort of given this incredible disparity in maternal mortality, is there a way that we can think about it? And in particular, the question that I have is, can we really think about the lessons that Martin is going to discuss for us, and apply these to the so-called 3 delays as approach to solving this problem? Now, I don't know how many of you are familiar with Lord Crisp's great monograph on learning from lessons in low and middle income countries, which he's aptly titled "Turning the World Upside Down." But that's what we're going to try and do here, is we're going to take Martin's example, and within the WHO framework of the 3 delays, which I'll show you in a second, and can we apply that thinking to similar situations that are so different in the United States and in Europe? So for those of you who are not familiar with driver diagrams, the driver diagram is really just a simple way of constructing our theory as to what it is that's going to take us to get to our aim. So our aim in this case is how do we reduce maternal mortality and morbidity? And the three delays model, which are the 3 primary drivers, are, firstly, a decision has to be made to seek appropriate medical help. So the mother has to be equipped with the knowledge to be able to seek appropriate help. And I think Carol will help us translate some of that to what other decisions need to be made at the front end that might drive improvement. The second is, and with that knowledge, are the logistics in place in order to be able to get the mother to the right place at the right time? And thirdly, when the mother does get to the right place at the right time, is the team equipped and ready to do something about it, or to provide care reliably? And then the secondary drivers, really, the beauty about having this construct is that we can then work back and say, okay, well, what are all the ideas that we can test, and in order to be able to arrive at these 3 drivers? And particularly if we're doing a spread project, those will be our tools as we go forward to be able to understand. So I'm going to hand over to Martin, who's going to tell you a little bit about the Malawi Project.
Good morning once again. So I'll give you a brief context of Malawi. Malawi has a population of about 13 million people, and the 2010 DHS Demographic Health Survey revealed that we are having 675 maternal mortality rates, like mothers dying per 100,000, which is way much higher when you look at developed countries. And I think Pierre did highlight in what we have in Europe and in the US. This project was actually designed about 5 years ago, and the key goal or aim was to reduce maternal mortality by 30% by February 2012. Right at the beginning, there was a lot of rigorous research and evaluation to understand what the key drivers or what the key causes of maternal mortality were. And it was realized that PPH was accounting for about 27%. And eclampsia and preeclampsia was accounting for about 9%. And then sepsis, because this is a high HIV prevalent area, was accounting for about 22%. Now, getting to the driver, as Pierre mentioned, as I said, the aim was to reduce preventable death by 30%. And then these were our key primary drivers. So the initial one was to reduce delays in deciding to seek care. This was mainly towards interventions that were very specifically designed to work at community level through community mobilization. And then the second delay was more now looking at if the mother decides to go and seek care, how long does she take to get to the facility? If you live 20 kilometers away from the facility, you take longer than if you live 5 kilometers away from the facility. If you have a car, you take much shorter compared to someone who doesn't have a car. Malawi is predominantly rural. If it's rainy season, then the roads are impassable, so it's much more difficult to get to the facility. So that accounts for delay 2. The third delay is now you've decided to go to the facility. You've made the effort to get to the facility. When you get to the facility, how long does it take for healthcare providers to give you the care that you've come for? So for the first delay, what we looked at was how could we empower women so that they can develop the capacity to make informed decisions. So what we did was more economic and education empowerment. So we did a lot of community mobilization and also community sensitization. We also worked with these communities to develop supportive structures so that they can be supported in order to move from one place to the other. But then we also worked very closely with these communities to give them information on the advantages of delivering at the facility. For the second one, we worked still with communities. So for delay 1 and delay 2, our approaches were mainly at community level. One, to promote communication and transport, but also birth preparedness. Birth preparedness is what we mainly looked at was if the husband knows that the expected date of delivery, then if they have a bicycle, they should make sure that the bicycle is in good condition to ensure that if there's as they get closer to the date, then they should be able to transfer the baby. But also we put in place effective support systems. I'll describe in a minute, but we worked with these communities to ensure that they have at least a bicycle ambulance in their communities, which would help to support these mothers to get to the facilities. And then reliable referral systems was more the linkage between the community and the facility, to ensure that they know what to expect at the facility when they get there. In terms of addressing the third delay, we worked very closely with healthcare provider now. So this is now at facility level to ensure that we work on the staff attitude. And this very closely links with the attractiveness to health services. There are a lot of trends, and as in Malawi, it's very close to the situation in Ghana where human resources is a big problem, and these people are usually overworked, under a lot of stress. So there are instances when, instead of assisting patients, they start shouting at them. So we worked towards staff attitude, but also we worked very closely with staff to improve their knowledge and skills on delivering the emergency obstetric and neonatal care. But we also worked with them on the use of data for decision making. So this is a pictorial presentation of what I just described. As you can see on the top right-hand corner, that's a women's group, team meeting and discussing. What these women's groups do is they identify the problems within their communities which are contributing towards the increase in maternal and neonatal mortality. They come up with solutions, they propose solutions, and then they come up with interventions. So there are others that would, so if let's say a community is 20 kilometers away from the facility, most likely they are going to identify referral or transport as a major problem. So they are going to work towards getting a bicycle ambulance for their community. But then if you have a community that is close to the facility, most likely maybe they'll come up with, let's say, anemia. So what they will do is come up with a way of identifying blood donors so that when they get to the facility, blood is readily available in case the mother would need blood. We also have task forces, which is mainly like act as a linkage between the community and the facility. And they are supported by what we are calling health surveillance assistants. These are part of the Ministry of Health employees, but they are based at community level. We also use breakthrough series of quality improvement, the famous PDSs. And we work with healthcare providers. We form quality improvement teams at both health facilities and referral facilities to ensure that they improve the quality of care that these people are seek. So basically, this model, you should look at it as the demand and supply. So we create demand through our community structures, but we ensure that health facilities are prepared to meet the demand that we've created at community level. So these are the figures. Through the 3 districts that we're working in, we formed 650 women's groups and 707 task forces. And then we had 13 CMOCs. CMOCs is comprehensive emergency obstetric and neonatal care centers. And these are a little superior to health centers. They are superior because they provide 2 extra signal functions. So they're able to provide blood transfusion, but they're also able to provide cesarean section. So this is now more like, how do you link a woman who's coming from the facility, from the community? If she is high risk, then during the community sensitization, after they are identified during antenatal clinic, then they are advised to go straight to the CMOC instead of going through the health centers. So we formed 13 QI teams in CMOCs and then 42 in our health centers. Our role as well, we work very closely with the Ministry of Health at central level to help on policy, but also work with the ministry on our implementation strategy. So I think this is just to summarize what I've described. So demand, more at community level, but also at community level, we work more on referral and access. So if you look at these 2, you'd look at them as delay 1 and delay 2, demand and then referral. On the last one, it's more now quality care services at facility level. These are some of the results that we've realized so far, and this is a very updated data. So all along the last 5 years, we're using women's groups. What we realized is there was no clear linkage between the community and the facility, so we decided to form task forces. So in March, we formed 81 task forces, and in May, we formed 166 task forces. You can see the number of, the number increasing on the total deliveries at CMOCs, and then a corresponding increase on the total deliveries at health center level. In terms of outcomes, we track maternal case fatality rates each and every month. So this is a U-chart showing the tremendous reduction. When you look at the first one, that's around 370 deaths per 100,000. And then now we are, we hope that trend continues, but we are around 260 case fatality rates each and every month per 100,000. We'll be presenting the details of this presentation, of the outcomes of the 5-year randomized control trial later this evening. So please, you're welcome. And we'll be distributing leaflets as you go out. It's in room 352. But just a snapshot of the outcomes. The randomized control trial, which was done by an external evaluator, the University College London, showed that a combined approach, combined intervention. So in places where we had both community and facility interventions, we're able to reduce 22% neonatal mortality. and then 16% where we only had community interventions of perinatal mortality. There was no observed reduction in maternal mortality rate. There was a general trend in the reduction, but then there was no, we noticed that in both intervention sites and in control sites, the reduction wasn't statistically significant for maternal and neonatal mortality. Thank you so much.
Thanks, Martin. Before we move on to the translation part of the presentation, I just wondered if there were any immediate questions for clarification. We're going to try and limit this, and certainly there'll be plenty of opportunity to, there's a full hour and a half this evening on it. So I just wanted to take a couple of burning questions for clarification. I see 4 hands go up immediately.
My name is Doha Saleh. I'm from King Saud University, Saudi Arabia. I was wondering about the composition of the task forces and the nature of their work. Thank you.
My name is Katherine Pirkle.
Okay. So the women's groups, the task forces were, in Malawi we have structures, like we have villages, group villages, then traditional authority. These were mainly established by the village health teams. So most of them, it's like 50-50, 50 men and 50 women, whereas the women's groups were predominantly women. And their roles, one is to provide sensitization or to mobilize pregnant women for area antenatal attendance. So what they do is they have a register. They record each and every pregnancy in the community. They also provide basic counseling on the advantages of area antenatal attendance. They also promote and help to motivate women to deliver at hospitals, but also the 7-day postnatal check. Yeah.
If I could just add, sorry, Martin.
Yeah. They also do, so the task forces are a link between the facility and the community. So what happens is, if a nurse identifies a high-risk pregnant woman at a health facility, it gives a name to the task force member. This member makes more regular visits to this woman, but also encourages her to deliver at a CMOC instead of a health center.
I just wanted to answer the question about the composition. So each village contributes one elected representative to a team of 12, so it's 12 villages, overseen by the head, the regional head, traditional head of that region, and then with the outreach healthcare worker from that facility where everybody goes to for referral. So it's a healthcare worker from the facility, a traditional head, chief, and then 12 villages on average with one representative each.
And the villages in Malawi are very compact. So like they're very close together. It's not like big distances. Yeah.
I think we just take 2 more quick questions, yes.
I just have 2 clarifications I'd like to ask. My name is Katherine Pirkle. I'm from the International Health Unit at the University de Montréal and the Institute for Research and Development here in Paris. My first question is, your intervention targets the 3 delays. Your outcome measures are in terms of neonatal, perinatal, and maternal mortality rates. But what's the mechanism by which you're trying to reduce the mortality? Is it through increased utilization in people at high risk? Is it increasing assisted delivery? What is the actual mechanism you're trying to achieve this end result with? The other question is in terms of financial access. How much is emergency obstetrical care for patients? So how much is it for a cesarean, for example?
Maybe I'll start by answering the last question. Healthcare in Malawi is predominantly free. It's predominantly free, but then there's a lot of gaps as well because it's run by the government. There are a lot of gaps in terms of resources, supplies, and medication. And when we were discussing, we felt that maybe one of the contributing factors towards, like no reduction in maternal mortality rate is because of lack of resources. When you look at our trends in the previous one, in this slide, we can directly attribute some to lack of resources, basically at CMOC level. in terms of your first question, our target is more like to increase access. As I mentioned, we mobilize communities to ensure that they seek medical care at health facilities, and then, but also to reduce the delay. So one of the key things is before there were a lot of traditional birth attendants, a lot of home deliveries. What happens is by the time these women get to the facility, it's too late. They can't help them. Even with lack of resources, at least there's something that they can do with the little resources to save these mothers. So in terms of access, what we do is promote access or promote hospital deliveries, but also antenatal. There's a lot of activities that happen during antenatal visits that if these women accessed, then it would help reduce maternal and neonatal mortality. Thank you.
And the other thing that the Maikanda group has done really well is once they get to the facility, they have the change package. There is a bundle of activities for each of the 5 causes of maternal death. So for hemorrhage, hypertension, obstructed labor, etc., there are a set of must-have activities. 3 or 4 things have to happen for every woman. And they've done an amazing job of tracking the performance of the delivery of those few activities to be able to show high reliability of those activities in order to be able to avoid those 5 causes of death. So it's working at the 3. So that's a good way to go back to the issue of the drivers. So just before I get there, the single figure, and Martin and I didn't correlate our numbers, but these are the latest numbers from the WHO about maternal mortality rates in the US. But that 24 hides tremendous variation within the country between non-Hispanic white, non-Hispanic black, and Hispanic, as you could see there. And in addition, you will see that the leading causes of death in a high-income country like the US will be a bit different from those in Malawi, with a much higher proportion of indirect causes. And if we go over to Europe, to Denmark, those indirect causes start to become the better performing your health system is, the more you're going to start to see some causes of maternal mortality which you don't see in low middle income countries, particularly around thromboembolism. But you'll also start to see more influence from the indirect causes, and that may be just better reporting or better classification rather than actual differences. But there are differences that need to be taken account of, and as we heard in the last presentation, context is really everything. So just getting back to this issue about what can we learn from this extraordinary story that has come out of Malawi, and the way that this very comprehensive approach about trying to reduce maternal mortality. The first delay in seeking appropriate help, the logistics question, and the reliability question. We could start to make the transition to a more high-income type environment by thinking, but keeping to those themes, and whether the theme is whether your microsystem is the obstetric unit that you work in, or your microsystem is the antenatal care and obstetric unit, or perhaps, and I would encourage us to start thinking outside the bounds of that and really into the community, irrespective of the economic context in which we're working. There is a decision-making process and an engagement of the mother at the very start of this process, which I think is absolutely crucial. There is an issue around logistics and planning, which I think is common to all of our responses in the situation. And there is, of course, the issue about reliability, which I think it has been the sort of primary focus in high-tech and more high-income environments. So what I'd ask Carol to do, perhaps, is to reflect really on her experience of the success or lack of success, perhaps, in using this model, and the potential, I think, that exists for us to start thinking in these kinds of terms in a more comprehensive way about how we might tackle an improvement project on maternal mortality in any setting.
Yep. Great. I'm going to just talk from here because I have my slides in front of me here. So a couple things. My colleague who's with me today, Pat O'Connor from Scotland, we've done a tremendous amount of work in Scotland, not a great, in patient safety, not yet a great deal in maternal, although it's just starting. Gave me a reference that is an inquiry about why mothers die in Scotland. And so it's a wonderful compendium of all of the understanding and all of the studies, all of the inquiries about why mothers have died. And as Pierre says, it's quite different than the list. It's quite alike the list of Denmark. It's quite different than the list for Malawi. But still, if you look down the list, it's very clear that the 3 delays model would be extremely helpful, and I'll give you just an example. So one of the causes, and quite a high cause of death in Scotland, and I think probably in the developed world, is poor use of specialist anesthesia for women who are high risk. So the 3 delays model here, one is that the first delay is probably failure to realize you're in a high-risk situation. So how do you understand that, okay, we're not in normal ground here? The second is getting a specialist OB anesthesiologist on site. This is not a simple thing. It depends where you are. If you're in a referral center, if you're in a small community hospital, depends on where you're giving birth. So getting those people on site is not always the easiest thing. And the third is, once they arrive, understanding what's going on with the patient so that they can intervene quickly, because these are often life-threatening situations. And that ability to communicate quickly and carefully enough so that they can appropriately intervene is very important. So I don't think, even though the delays are different in Malawi, the 3 delays model I thought is very helpful. And actually I looked at 2 or 3 of the other causes, and they're all time related. They all really fit. The failure to recognize, the once recognized the call for help and the delay in getting that help, or timeliness, I should say. It's not always the delay. Timeliness in getting that help. And the third is, when they arrive, does the right thing happen? So thinking even beyond, but somewhat related, I guess, to beyond maternal health, it's exactly what we see in sepsis. And some of this is maternal sepsis. Whether it's sepsis where the patient develops sepsis on an inpatient unit, or whether they come in through an emergency department. Actually, you have a much better chance of surviving sepsis if you come in through the ED than if you develop it in the hospital. Because we slowly get used to your failures, and they don't seem startling to us until you're almost dead, till you're exhibiting very, very late signs of sepsis, moving quickly onto severe sepsis. And then we have to transfer you and you die in the ICU. So not a great deal of help there. When you come in, though, through the ED, and there are stories, and many of you will know them, of failure to recognize septic patients in the ED. Often the patients take the first delays, they don't even come to the hospital because they think they've got the flu. And so trying to even get this word out to the community to understand what really flu versus very sick looks like is not a small thing. And we see many patients coming too late. So let's say you come, you've been ill for an amount of time, you're febrile, or maybe you're not. You don't necessarily have to be febrile. In fact, you may be may have a subnormal temperature. You arrive and you're put in a queue because it looks like you have the flu. So failure to recognize the septic patient in the ED is a problem. The second is, once they recognize, it's getting everybody together to do the right thing. The third delay is, honestly, quite frequently, it is what we're going to do next with the patient. Are we going to put them in ICU? The communication between the ED and the ICU, there's no love fest going on between those two groups. And so trying to get those two to communicate on a total management plan, I can tell you, having worked in this area a long time, that the ED will say, we're not going to cooperate with the ICU. The ICU has no vested interest in cooperating with the ED. They think they've got 2 separate domains. Meanwhile, the patient's lying on a gurney in the hallway. So I think this this system of 3 delays probably has a lot to do what we do with them when we have secondary drivers for all of them, things we can do for each one of them. But it's probably a model that really bears us thinking about those instead of just an aggregate of clinical problems. When you look at why mothers die, the discussion is failure to get a well-trained OB, high-risk anesthetist. But they don't go back to say, well, wait a minute, the first failure was you didn't recognize you needed one. You didn't recognize you had a high-risk mother there. So I think the model actually has lots of applicability in the first world or in high-income settings.
Thanks, Carol. So we have 10 minutes left, and I'd be interested, for those of you, particularly those of you who work in obstetric situations, to know whether, in fact, your focus really is mostly at the sort of third delay, high reliability end, or whether you've successfully been using this kind of a model, or could use this kind of a model in thinking about a more comprehensive way of engaging mothers, of engaging communities, and some of these transition structures that were shown in Martin's presentation.
Pat O'Connor from NHS Scotland. I think there's a lot of similarities in the model that should and could be applied to the Why Mothers Die interventions, because this is national audit information. It's recorded throughout the whole of the UK, not just in Scotland, and the same messages are reported whatever the report comes out, I think it's every 2 years. So delay, not just in anaesthetic care, but failure to recognise by the entire obstetric team. Now, there's not the number of ICU beds in the UK that there is in the US. It's not easy to access higher level care. And most of the Why Mothers Die reports always have that delay in recognising that this maternal patient does not have the same physiology of even recovery as a normal non-pregnant woman. So there's huge delays in failure to recognise, and then there's more delays and, certainly from personal experience, panic about what to do next. So there's something in that third box about reliability, sustainability, skill, in being able to call additional help. I think there's also a relationship with the failure to access maternal care in the first box, and certainly not to the same scale as in Malawi, but the demographics of populations that do not access any kind of care apply to maternity care. They don't come to hospital until something horrible's happened. So even when you have a hospital facility, I think these 3 primary drivers absolutely map over to whatever bit of the world you're working in.
Right. I wondered if there are any, I mean, I think the opportunity here as well is engagement of the mother. I don't know whether any of you have had experience of really the powerful role that the mother could have in recognizing her need to have something different than what she's getting, and her ability to be able to influence the situation. So in Malawi, the whole purpose of the women's groups is to give the mother that knowledge that she actually needs. It's not just because she's being told that she's a high-risk pregnancy that she needs to get to the emergency facility, but it's her life that she's taking in her hands, and she's making a decision to come, and then to know what to expect and to kind of demand it if she doesn't get it. I don't know whether any of you have tried or have incorporated that thinking into your clinical responses and improvement.
Thank you very much again for this opportunity. I work in Ghana with the Ministry of Health. I worked from the district level up to a provincial level. I've gone through all these experiences. In Ghana, in fact, generally speaking, this model works everywhere, but it must be contextual. In the resource-endowed areas, you can have the delays between departments, just like the way you rightly described. In resource constraints areas, you can have delays, geographical delays. But in the case of Malawi, the way you've described it seems like Malawi is even better than in Ghana. Let's begin with the first delay. In Ghana, the first delay, getting the mothers to agree to even start seeking for health care cannot be addressed easily like you really described, because we have this kind of serious sociocultural beliefs where the mother, expectant mother, needs the permission from the father-in-law before she can even decide to seek for help. So merely telling her that it's important, this pregnancy can land you in death, is not enough. Somebody else has to give her the permission to do so. And in our case, it is extremely difficult to work around these belief systems, which take a long time because they've been traditional beliefs, so we have to work around. So in my situation, it would be too early to use an intervention of this nature for 3 years and expect outcome. But the method is the same. You just look at it, look at the context, and then carve around it. Then the second one is the second delay. In your case, you have these nucleated settlement patterns, and they are not too far. You have so many health facilities. I'm in charge of a region where I have 6 hospitals, and they are like two hours. Some of them are 2 hours apart. So if you are living in a community where during the rainy season, 2 hours, a bicycle ambulance is completely useless. Even a motorized one is useless. You need a high-wheel ambulance. So in situations like that, we have to find different mechanisms. So we have what we call community emergency transport systems, where the community members that you have, they come into agreement with somebody who has a 4-wheel drive vehicle somewhere that can be reached by a telephone or something. But the birth preparedness plans is quite appropriate. So I think that generally speaking, the model is just a good model that can be applied. But then it has to be contextual. Thank you.
Katherine Pirkle again. I work in Mali and Senegal, and we've been working on, my group has been working on maternal mortality for about 25 years in the region. What we were able to see in terms of, we work on all 3 delays, and all 3 are very important. But the biggest changes in maternal mortality that we've witnessed have come with 2 changes that were structural at the level of the health system. So the first major one was when the governments decided to make cesarean sections free. That made a huge difference in terms of financial access and increased the utilization of health services and brought down maternal mortality rates. We have some very strong evidence coming out of the Kai region in Mali, which showed that by making not just cesarean sections, but referral and evacuation free to the patients, that we were able to bring significant drops in the maternal mortality ratio in the region. So that's why I was asking about financial access. Most of the evidence out there, particularly in very low-income countries, suggests that the biggest disincentive for using health services and getting emergency obstetrical care when it's needed is the financial part.
I wondered if I could ask Martin to respond to that, because there was a very interesting parallel situation. I think that there are you're absolutely right in saying there are multiple factors. In Malawi, there was another factor that drove attendance at skilled delivery that was not financial.
Here, I'll give you this one.
Okay, I think one of the things that the Ministry of Health or the government did in 2009 was to ban the use of traditional birth attendants. So that also, like that, because like in 2004, the maternal mortality rate was 984. And then now it's 675. And we actually saw a huge increase in the number of women that were coming to the health facility. Of course, the demand is really high, and then the system was not prepared to meet the demand that was created. That's the challenge now. But that did help reduce the number of deaths. And as I said, that in Malawi, cesarean section, or like in general, healthcare is free to everyone. So like a woman doesn't have to pay to access cesarean section or get a blood transfusion. Yeah.
Thank you so much. I'm Apollo from Namibia. My question is on the traditional birth attendants. You mentioned that most of the mothers actually go to the traditional birth attendants.
So was there any effort to train those traditional birth attendants to maybe recognize high risk pregnant mothers and then refer them to hospital?
So before 2009, there was a huge effort and through UNICEF, where they were training and supporting and providing what they were calling hygiene kits for traditional birth attendants. But there was still a lot of deaths happening there. What now is happening is we're still using the traditional birth attendants, but their roles have changed. They are now acting more as referral agents and not necessarily delivering at community level. So they are referral agents. So when these people come, because they are recognized, and I agree that there are a lot of cultural issues there, but what now they do is they got a training on their new roles, which is basically referral to the health facility.
Well, we've heard a lot about the 3 delays. I want to avoid the 4th delay of ending the session late. So I'm declaring the session closed officially, but please stay on and ask questions of the speakers. They'll be hanging around. And thank you all for coming and participating in this. Thank you.